My name is Tony Philly, as you mentioned. I'm actually in private practice down in Carmel, California, about 2 hours south of here. I get to work at this beautiful hospital and did an ultrasound fellowship here many years ago and have just been coming back to do a lecture like this every year since then. So being in private practice, I will have a little bit of different take. I know some of you are here to study for the certification boards or something like that, and then a lot of you are in practice. So I'm trying to mix it up, a lot of stuff that's clinically relevant as well as some things that you might just need to know for a test. So with that, we'll just get started. I'm going to do kind of a similar format, just some cases. There'll be a history here. I tried to add multiple choice questions this year just to kind of, if you are taking a test, you can kind of prep for it in that way. This one's pretty basic, but shown for a specific reason. So it's a spectral Doppler study. Just want to get you used to, looking at this chart and knowing what these numbers are. So this is a greater than 70% stenosis. And we see they're placing the spectral tracing right where the color flow aliasing is the highest, so that's the appropriate place to put your spectral Doppler tracing. And we see a peak systolic velocity that's 344 centimeters per second, or 3.4 meters per second, so that's greater than 230, and an elevated IC-CC ratio. So most of us, if you read these, have this chart sitting around next to the workstation somewhere. Most people don't memorize it, but if you're taking the test or something, then instead of trying to memorize the whole thing, I think it's good to just focus on a couple numbers. And if you look at this 50 to 69, anything above it obviously is bad and anything below it is good. So if you kind of just remember 125 and 230, that'll put you at 50 and 70%. And if you remember 2 and 4 under the IC-CC ratio, then that'll also put you at 50 or 70. So this is a cine clip. I will tell you it's an OB ultrasound if you didn't catch that. And just try and figure out what you think it might be. And this is none of the above. So this is actually a sacrococcygeal teratoma. And the reason I show this case is, you should probably know what one of these looks like, even though most of you, if you're in practice, won't see one. But again, from testing purposes, it's good to know what a sacrococcygeal teratoma looks like. But more importantly is actually to show a point that a lot of people get screwed up when they see these on tests. So if you're scanning an obstetrical ultrasound, you're pretty much going to know where you are in the body because you've got 50, 60, 70, 80 images. However, if you're taking an exam, they might just show you one image or one cine clip. And what happens a lot of times is people look at this and they just kind of look at it quickly and they think this is a really messed up head, which is why I kind of put a lot of those choices in there. But the key is when you're looking at an obstetrical ultrasound, to start to look at the bones first. The bones will help to orient you where you are in the body of the fetus. And I just love this. There's a scene, if any of you are Monty Python fans, from Holy Grail, where he's like, look at the bones. And kind of an obscure reference, but always something I try to get people to remember. So if you want to use the bones in a fetus to know where you are, because if you know where you are, at least you can narrow your differential. If you're up in the head, you should obviously see some skull, assuming there's at least a decently normal head, although the brain may not look normal. If you're in the neck, that's one of the trickier parts. You should see the spine, not much soft tissue anteriorly, and you may see the clavicles. In the chest, you'll see spine again and ribs, and obviously should hopefully see the heart. In the upper abdomen, again, the spine, the lower ribs, some stomach. In the kind of mid-abdomen, you'll again see the spine, so that's a really helpful thing. And here in the pelvis, you should see the iliac wings as well as the lower lumbar spine or sacrum. So if we go back to this case, I don't know if that'll play. You see the spine here, and then here's some shadowing ribs. So that actually tells you right away that the head should be up here, and this is actually an iliac wing, which is kind of a higher level observation. But the ribs and the spine themselves would at least point you to the fact that this is the sacral region and not the head. Here's the next case. So this is a cine clip. There's this sort of large mass here with homogeneous echoes, and this is hematometrial colpos. This is the uterus actually squeezing blood into this obstructed vagina. So here it is in a cine clip. We've got the uterus, a large distended obstructed vagina. I put endometrioma on that list because it looks a lot like an endometrioma. It actually kind of is, in essence, the same. The reason that is because endometrioma is old blood products. This is old blood products. So we have hematometria, blood in the uterus, hematocolpos, blood in the vagina. So down in here somewhere there's an obstructed vaginal opening. So back to the fetus again. So a cine clip showing the heart with a couple of choices here. Figure out what you think it might be. And again, this is none of the above. So what happens is a lot of time people, they're looking at the heart and they're starting to think, okay, what's wrong with the heart? What's wrong with the heart? This is actually a congenital diaphragmatic hernia. The problem with the heart here is that it is completely smashed up against the right side of the chest, and the stomach is up here inside the chest with some liver and bowel. And when you look at an obstetrical ultrasound, people always talk about the 4-chamber view of the heart, which is an important view to get. You want to look at the 4 chambers. Again, I always start with the spine, and you can see the descending aorta here. If you want to identify the chambers instead of just calling them 4 chambers, you want to actually look at this and say, okay, here's the aorta. Touching the aorta is the left atrium, which makes that the right atrium, which makes that the right ventricle, and the left ventricle. And in the right ventricle, you'll have the moderator band, and it's also the most anterior chamber in the heart, assuming the heart is normally developed. So it's great to do that, and you want to do that on your 4-chamber view, but just as important on the 4-chamber view is to assess the position of the heart within the chest. And the position of the heart is actually going to be your big tip-off as to whether there's a chest mass that you may or may not see. So what you want to do is draw a line from the spine right through to the sternum, which is right here. And if you draw that line, the right atrium, which we already identified, should be to the right of that line, and it'll cut through the right ventricle and left atrium a little bit. That's a normally positioned heart. There is not going to be a consequential chest mass at this point. You also want to, in your mind, I'm not drawing these lines actually on the images every time, but you want to draw a line down the interventricular septum, and you should see about a 45-degree angle. Again, you're not pulling out protractors and measuring this stuff, but if you see that, then you have a normal cardiac axis. If you have a normal cardiac position and a normal axis, you're not, again, dealing with any kind of significant chest mass. So you'll see sometimes people are taking pictures of the diaphragm and all that stuff, which is fine. More pictures, I think, is always better. But this is how you really want to look for a chest mass. That's your first clue. If you notice back here on this, well, here, actually, I'll go here. So if you draw your line here, the heart is basically completely shifted to the right side of this line. But what I wanted to point out was that this is liver, this is lung. If you didn't have the stomach here, liver and lung look pretty much identical. So if you have a bowel only or liver only congenital hernia, you're not going to actually necessarily see the mass, but you will see the abnormal cardiac position. So that's really the thing you want to focus on, more than just counting up and seeing that there are 4 chambers in the heart. And just as a caveat, if you do look at the 4-chamber view of the heart, make sure there's actually 4 chambers. Don't just assume there were because the tech took a picture and labeled it 4-chamber. Really go through the process, make sure there are 4 chambers, and we can go over that a little more later. So this is a relatively easy mini case, but I'm going to show it for a different reason. And what would you expect to see on spectral Doppler flow? This is color Doppler. So spectral Doppler flow is to and fro flow. So this is a pseudoaneurysm. Hopefully everyone knew that, with this classic yin-yang type appearance. But what happens sometimes in more sort of real life situations is that it doesn't look just like this. If you see this, you're done. But what you deal with sometimes, and any of you have done this knows, you get this person with 10 million bandages and you can't actually get a good picture, and they have all this big hematoma and it's thick and the tech can't get anywhere. And you're seeing like flashes of color here and there, and you see this big hematoma and you're wondering, is that really a pseudoaneurysm? There's little flow in there. Is it a side branch vessel? That's real life. So what I want to point out is that, so here's a normal femoral arterial waveform. Here's a nice pseudoaneurysm. That's not going to be a problem. But in this case, you don't see a whole lot of flow. Actually, probably color. Well, no, there's a color box on. So there is color on. You're not really seeing anything. But there were flashes here and there. So what you want to do is find the vessel and find those little flashes of color that are going towards the area you're worried about. And that's the neck of this thing that's shooting out. And what you want to look for is this to and fro flow. Not this, but something that looks like this. So when you're really trying to troubleshoot one of these, this can be really helpful to know what you're going in and looking for, because a lot of times it's really tricky to image these if it's not just a big old honkin' pseudoaneurysm like that. This is a newborn who had a myelomeningocele. Just happened to be the history in this case. It didn't necessarily have to be the history. And this is a complete hip dislocation. The reason I wanted to go over these is because neonatal hip studies, which many of us are asked to do, are one of the toughest studies to technically do. And if you don't know what you're really looking for on top of that, it makes it even more difficult. And the fact that we kind of look at these in this weird orientation, I think, causes a lot of people to get confused. So for better or for worse, this is how we look at a neonatal hip ultrasound. You're actually scanning in from the side, so you're almost in a coronal plane, almost even kind of from the back. And so it kind of gets confusing as to what we're looking at. So I'm going to just try and change our orientation for a little bit so you can understand. This is more what we're used to looking at. So if you turn that image on its side and compare it to a normal hip, what we're looking at is the superior acetabulum there, just like that. This is the labrum, and that's, of course, the femoral head. So basically, you're looking at this picture turned on its side. What we measure is what's called the alpha angle, which is actually this angle right here. And you want to draw a line down the iliac wing here and through the acetabulum like this to get the angle. There's all these different numbers that are, sort of, if it's, the baby's at this gestational age or that gestational age, it could be, 55 is normal or 60. Honestly, just for ease sake, I would stick to greater than 60 degrees is normal. And the other thing you want to look at is that the femoral head is about 50% covered or more. If it's less than 50% covered, then you may be dealing with a shallow acetabulum. The tricky thing, again, with this case, we just had one the other day where I had to bring the patient back to re-image him. You can easily make this angle look abnormal, but you can't make it look normal if it is abnormal. So if you're getting 50, 52, 54, and then you get one that's 62, it's 62. Because you can slide off on these things in weird angles and make it look really shallow when it's not. But you can't make one that's 62 look 55. So just a good tip to remember. In this case, this is that iliac wing here. I'll turn it on its side again. This was that iliac wing. There was no acetabulum. This thing is fully dislocated here, and it was sliding up along the iliac wing there. You can see here. The only time I've ever seen someone make it look normal when it was abnormal was that there was some artifact down here, and they actually started measuring something that wasn't even the acetabulum, but it was one of these ones where it was so abnormal that someone didn't even quite get that it was abnormal, and they started measuring it as normal. Okay, next case. Person had a right orchiectomy. This is their left side. And this is microlithiasis. We call it classic microlithiasis. So this is what we call classic testicular microlithiasis. When I was training, we just called this microlithiasis. Since that time, someone decided to break it up into limited and classic. Limited would be less than 5 microliths per image. Classic is greater than 5 microliths. The problem with this is that limited, I think most people would agree there's no clinical significance. Classic, most people agree that there is some increased risk of cancer. But the problem is there's not a lot of consensus, and it's not a really clear-cut progression to malignancy like, DCIS or something with calcifications. So we're often stuck with this thing, okay, now we've got microlithiasis, and what do we do with it? Different people say different things. Again, there's no consensus. Basically, what I do is report it. If it's coming from a urologist, then I just report it to them because they know what they want to do with it. If it's coming from a primary care physician, I'll say something like, there's testicular microlithiasis, there is an increased risk of malignancy, refer to urology. And I think the urologists have a good sense of how to manage it. People used to say, get yearly ultrasounds. There's no consensus on that. People used to say, do ultrasound alternating yearly with HCG and like those kind of, hormonal labs. Again, I would just put it into the urologist lap in your community and move on that way. So this was actually the real history. This father was carrying his baby in one of those baby Bjorns, and it kicked him. So that's clinical history is important in this case to figure out what's going on. And the answer in this case is follow conservatively. Again, up to the urologist, but that is the typical course of action. So this is a tunical hematoma. So here's the tunica, is this bright echogenic line around the testicle. Here's normal testicle parenchyma, and this is a hematoma in sort of the subtunical region compressing the testicular parenchyma. And the critical thing here is to help the urologist or the ER doctor or whoever you're dealing with to triage this patient. And what you want to identify is whether this tunica is intact or not. So if the tunica is intact, they will typically watch the patient. If the tunica is disrupted, as you see here, and there's extrusion of testicular contents, that's going to require surgical exploration. Okay, this is a patient who presented with right scrotal pain. So these are grayscale and color images of the right, grayscale color images of the left. This was labeled right epididymis on the scan. So the question is this torsion, epididymal orchitis, a hernia, piocele? So does everyone have their idea in mind? And my question to you is there one other image you'd like to see? How many people, just raise your hands, thought this was A? How many think it's B? C? No one's raising their hand. Okay. So here's the other image that you always want to look at. And does this change your diagnosis? So this is right-sided testicular torsion. So our initial images showed this kind of heterogeneous testicle with tracing it actually shows arterial flow. Although here's the left side, kind of a more normal looking testicle. The arterial flow is more robust. And then you have this kind of heterogeneous, it was labeled as epididymis. The epididymis did look abnormal, but this is the spermatic cord as well. There is some flow in there too. But this is the critical image, the comparison image from testicle to testicle with color at the same image. And I saw a malpractice case of this 2 years ago, almost identical case, and then this one came across like my scan, our department, like 8 months later. So I mean, this is real, this happens. Don't think this is esoteric. This is super important. The reason this person got into trouble in this malpractice case was because they never took this picture. And they saw this, and actually the radiologist was like, yeah, I don't really like the look at that. The tech was like, no, it's fine. There's flow, trust me. Never did that picture. This is the critical image. So we had, this is what clinches it. So with partial or intermittent torsion sometimes, to occlude the flow, you need this 540 to 700 degree twist. And if you don't have that, you will see flow in that torsed testicle. And so flow present does not necessarily rule it out. So that's just a really important case. So this is thyroid ultrasound. Question is, should any of these be biopsied? And you can't really tell without some more information. This is a multinodular goiter. There's several nodules. The question is, do you need to biopsy any of these? And I bring this up to discuss the world of thyroid biopsy, which is, to me, horrendously confusing, unless you just stick to one. What I do is stick to these guidelines. There's several sets of guidelines which I'll go over. These guidelines right here, which were put out by the SRU, 10 years ago maybe, I think are the easiest to follow. People have said that these will miss some cancers, that they can miss up to 2% of cancers. And that is true, obviously. They've done the studies. What they tend to miss is these small cancers, because what you'll see here is there's no biopsy recommendations under a centimeter. So if you have an 8 millimeter cancer, you're not going to biopsy it under these guidelines. Now, the big thing I look for in these is microcalcifications. That's one of the big things. So with microcalcifications, if I saw an 8 millimeter nodule with microcalcifications, I would actually probably suggest that it get biopsied anyway. So those that might be missed probably wouldn't be missed necessarily, or many of them wouldn't. But even if they are missed, again, they're less than 1 centimeter cancers that tend to be, thyroid cancer in general tends to be sort of, indolent to a degree, and if you continue to follow them, they will grow. But there's no proven benefit necessarily of increasing life expectancy by treating the less than 1 centimeter cancer. So I use these in our reports, and I actually have a report. I kind of break it up like this, which I've found to be helpful in our own department. The techs, they scan every case the exact same way. right side, upper, mid, lower, measure the nodules in each section, and then we report it like that. And if you are running a department and you're doing it, and everyone's doing it in a different way, you know that just trying to compare from one year to the next year just becomes incredibly difficult. If you have them scan it the same way every time and report it, everyone reports it the same way every time, it will save you and them a lot of heartache. So that's our standard report, and then we put these guidelines at the bottom just to help the primary care physicians knowing what to send to us to biopsy. Otherwise, we'll be sending everything for biopsying. So now they've started to develop something called thyroid imaging rad, TI-RADS, go along with BI-RADS and liver RADS and lung RADS and all this stuff. You got to have more and more RADS. These are great, and kind of will show you the different things that will help to make you more concerned about something that is malignant or not. Again, you'll pick up maybe a couple more smaller cancers than you will with the SRU guidelines, but we may be moving in this direction. The ATA guidelines look something more like this. They do take size into account and take all these different descriptive things into account. So if you kind of look at this highly suspicious one, those are the ones you really want to know. Again, the microcalcification, these what they call really, really hypoechoic, exceptionally hypoechoic nodules, anything that sort of breaks through the capsule, broken or disrupted eggshell calcifications. So those kind of things, obviously any adenopathy. So if you stick with the SRU guidelines, but kind of keep these things in mind, if you see a smaller nodule, it can kind of help to increase your rate of pickup without making it excessively complicated on everyone to report. So this is back to OB ultrasound again. History with size less than dates. So there's one observation to make here. And I'm going to show another picture. This is in this baby. So this is bilateral renal agenesis. So the first observation to make, which is sometimes difficult because it's an observation of something that's not there, and that's that there is absolutely no amniotic fluid whatsoever surrounding this baby. And when you have absolutely no amniotic fluid, the first thing to think about, this is like a second trimester fetus, is a severe bilateral renal anomaly. So when you go to look for the kidneys, there's generally three main possibilities. And almost always when you show a resident a case like anhydramnios, which this is, they say, well, it could be bilateral renal agenesis, bilateral multicystic dysplastic kidneys, or posturethral valves, which is all true. But when you're actually trying to make a diagnosis here, all three of those things look totally different. So when you're going in to look, if you have any of the other two things, you should be able to find those. The problem with bilateral renal agenesis is, again, you're trying to find something that's not there. You're trying to find that the kidneys are not there. And if some of you, I'm sure, read OB ultrasounds, and oftentimes you'll see, you get that picture and the text saying, here's the kidneys, and you're looking, you're like, I barely even see the kidneys. Because they kind of blend in with the surrounding tissue. So imagine if you have no fluid, the kidneys are even harder to see. So instead of going to look for something that's not there and proving it, we'd go and look for something that is there, and that's called the lying down adrenal sign. So this is the adrenal gland, has that typical sort of Oreo cookie appearance, and it's flattened because the reason it gets triangular is because the kidney grows and pushes it up, and you get that triangular shape. So if you have no kidney, you'll get this lying down adrenal. So again, the important things in this case, always look sort of globally before jumping into a case. There's no fluid. That's the first thing to identify. And when you see that, think about a bilateral renal anomaly. The other things that are always in the differential are ruptured membranes. Typically, there'll still be a little bit of fluid. Fetal demise, obviously the baby is dead, and it doesn't really matter at that point. This is posturethral valves. Again, looks totally different than what we just saw. Bilateral multicystic dysplastic kidneys, again, looks totally different than what we saw. The other thing I also see is people will see this and say, oh, it could be posturethral valves with bilateral hydronephrosis. Again, this looks like hydronephrosis. This doesn't look like hydronephrosis. You don't need to always throw these differentials out there. Again, they all look very different from one another. So here's a 9-year-old with right lower quadrant pain. And answer in this case is we can't be definitive. It is one of these things, but we don't know for sure. So what we did see here are multiple enlarged lymph nodes. So we're thinking about mesenteric adenitis, and we want to sort of jump to that diagnosis sometimes. But the critical thing is when scanning for appendicitis, unless you see something you are 100% confident is the appendix and you've seen it in its entirety, don't call it normal or don't call it not appendicitis, okay? I see this happen frequently. The tech will measure something like, I think that's the appendix, and I go in there and I say, no, that's some bowel. Really get to know what an appendix looks like on ultrasound, both normal and abnormal. I don't know if that's covered elsewhere in this thing. Maybe I should start adding that to this lecture, because it is something we're asked to do in more and more and more and more. And I frequently go in myself and scan and either find the normal appendix or find an abnormal appendix when a tech couldn't find it or called something an appendix that wasn't. So in this case, it was actually mesenteric adenitis. We did find the appendix, but just the key point is don't say that it's that until you've shown that the appendix is normal. So this is a image through the liver, elevated liver function tests. And this is metastatic disease. The reason I show this is because anytime you see calcification somewhere, we tend to just think it's probably benign, it's old hemorrhage, maybe old granulomatous disease. But in this case, you can actually see that there is some mass, solid soft tissue mass associated with this thing. And this error occurs most commonly in the liver, where we see calcified masses that are called something else. So this is a mother with hypertension. This is the biometric sheet from the end of an obstetrical ultrasound. And these, we get these all the time. They look, different machines look differently, but there's a few things you always want to tend to focus on. So I'll kind of point those out. So the clinical dates, ultrasound dates, the estimated fetal weight percentile, and the amniotic fluid index are the things you want to kind of pull out of these usually. So the question here is, what are we dealing with? Is this oligo? Is it IUGR? Should we be sending the person right over to L&D, or just send them home? So this is IUGR. And point out a few things. So the first thing you always want to look at on one of these biometry sheets, what are the clinical dates? It might be based on an old scan, it might be based on the last menstrual period, but it's whatever the obstetrician thinks the due date should be. And then the ultrasound date is what we are getting it to be. And you'll often see these plus or minus 17 days or plus or minus 13 days, all this kind of stuff. I completely ignore whatever that says. I'm not interested in what plus or minus 17 days, what the accuracy of it. If you know how to do biometry right, then you're getting an estimated gestational age, and that's what you got. And you want to compare it to the clinical dates. So in this case, it's 3 weeks less, and that's what you would report. It's 3 weeks less than dates. If it's 1 week less than dates, then you report it's 1 week less than dates. This baby, and then the next thing you want to look at, and this is really important, is different machines, this is what Acuson called it on this specific scan, the LMP percentile, which I think is kind of a weird name for this, but it's basically what percentile is this baby's weight falling in. And if it's less than the 10th percentile, that's IUGR. So the first thing you want to look at is this, then you go down to here, less than 10th percentile, you call it IUGR. You don't let that lady go home. They don't necessarily have to be delivered right away, but you call the obstetrician and let them know, I've got a baby with IUGR, what do you want me to do? Don't send them home and wait for them to get a test, because this can go bad really fast. And I see our techs and other people sending them home all the time. I'm like, what are you doing? So that's important to know. The question is, when you see IUGR, there's one other piece of information that you want to look at. Oh, sorry, before I go on. The amniotic fluid index in this case was 5.95. That's what someone measured. So technically, oligohydramnios is less than 5. Now, if any of you have ever measured an amniotic fluid index, you know that you can bump this cursor a little bit here and the baby can move a little bit there, and you can make 5.95, 4.2, or 6.8, whatever you want. So if you see a case like this and you're hovering on the borderline, I would just have caution to say that this 9.5 extra millimeters of fluid is not implying that this baby is any safer than it was if that 9.5 millimeters of fluid wasn't there. So basically you're hovering around the range of oligohydramnios. But there's one other piece of information that's really helpful, and a lot of radiologists don't really know how to interpret it or what to do with it, but it's actually really easy and can be really useful for the obstetricians. And that is the Doppler evaluation of the fetus. So we can measure the flow, the spectral tracing within the middle cerebral artery and within the umbilical artery. And in this case, it was extremely abnormal. The umbilical artery actually has reversal of diastolic flow, and the middle cerebral artery, which I'll go over what it should look like in a second, has really low resistance type flow, high diastolic flow. So is this normal? The answer is no. It's actually really, really abnormal. So what this helps is, so when you see a baby with IUGR, the obstetrician wants to know, how long can I leave this baby in there before delivering them? And they'll do non-stress tests and fetal monitoring, but they'll come to you to say, what's the amniotic fluid look like, and what do the Doppler tracings look like? And if any of those start to look bad, it's going to push them further and further along the need to urgently deliver. So rule number 1, the umbilical artery, so we measure what's called I don't have it on this side. We measure what's called the SD ratio, which is very similar to the resistive index. It's actually measuring the same thing. It's systolic over diastolic and that ratio, rather than getting sort of a percentage where it's systolic divided by systolic minus diastolic, or whatever the RI formula is. And then, so rule number 1, SD ratio should be less than 3. Rule number 2, the middle cerebral artery SD ratio should be greater than the umbilical artery ratio. So if those are true, then you have normal Doppler. So if you look at one, here is a Doppler tracing on the umbilical artery. Is the SD ratio in the umbilical artery greater than 3? Yes. Less than 3. Excuse me. Yes, it's 2.2. Is the SD ratio in the middle cerebral artery greater than 2.2? Yes, that's normal. That's how easy interpretation of these is. If this were 3.5, it's abnormal. I've actually never seen this be normal and this be less. It's usually that this is 3.6 and this is still 4.1 or something like that. It's only when this gets to be high and then this will start to drop below it. But when you start to see that happen, the baby is really in trouble because the brain is starting to get affected. So something that can be very easily incorporated into your practice, it's not complicated, and can be really helpful to the obstetricians. So this is pregnant with pain and bleeding. Sorry, this was a cine clip. So is this a normal embryo, have a thickened nuchal translucency? Is it a pregnancy of uncertain viability or embryonic demise? So this is embryonic demise. So in order to, we're going to talk a little bit about what constitutes demise and abnormal pregnancies. But in this case, we see here, we don't have an actual measurement, but we see this is these are centimeter markers. This is a pretty big looking embryo. If you've seen embryos, you should kind of have a sense of, how big one should be before you see a heartbeat. This is a cine clip and there's no heartbeat. So we can diagnose embryonic demise when the crown rump length is greater than 7 millimeters and there's no heartbeat. That is, you can confidently diagnose embryonic demise. I'm not sure if other people covered some of these sort of, I'll say, new-ish guidelines. Came out about 2 years ago for early pregnancy failure and ectopic pregnancy, but they are so important that I'm just going to cover them even if someone else did. So unfortunately, they were written, in my mind, horribly. So they decided to say that the goal of the guidelines for non-viability were to attempt at all costs to avoid a false positive diagnosis of pregnancy failure. It's a quadruple negative statement, which I don't even know what that means trying to read it. But what I think they're trying to say is the goal of the guidelines to diagnose embryonic demise were to say that if there's any chance that the pregnancy is viable, then we're going to do a follow-up. So that's really why things changed. They're trying to give us a specificity of basically 100% that this embryo is dead before we call it dead. So what does that mean? We're going to undercall a lot of embryonic demise, that they are demise, but we're going to say, oh, we need a follow-up. That you can decide in your own mind whether that's good or bad, but it is the way it is now. So if you see an embryo greater than 7 millimeters without a heartbeat, it's a demise. It used to be 5 millimeters, which even in of itself, if you saw, usually if you do, I'm sure you all do first trimester ultrasounds, you can see a 2 millimeter flicker of a heartbeat. This data that made these changes came out of England, where a lot of non-physicians interpret ultrasounds, and I think they were having a lot of screw-ups, and people were calling something probably that was an embryo not an embryo, and then they called it dead, and it really wasn't dead. So, because of that, they changed the guidelines for everyone. But now we're really, really safe, and if you see an embryo greater than 7 millimeters without a heartbeat, you can definitely call it a demise. The other thing that changed was if you see a mean sac diameter greater than 25 millimeters with no embryo, you can also call that a demise. It used to be around 18 millimeters, or some people even use 16 millimeters. So really, really safe guidelines now to call an embryonic demise. So if you see an embryo less than 7 millimeters with no heartbeat, you can do a follow-up in 7 days. If you see an empty sac between 16 and 25, you can get a follow-up, they say, in 7 to 14 days. In the guidelines, 7 is supposed to be suggestive, 14 is definitive. Again, we used to use 16 or 18 anyways, so if you're doing a follow-up in a 17 millimeter empty sac 7 days later and there's nothing developing, you can feel pretty comfortable. If you have a gestational sac with a yolk sac but no embryo, then you can get a follow-up after 7 to 11 days. And if there's no embryo with heartbeat after that, then you can be definitive. And this is now called a new term, pregnancy of uncertain viability. Should be the term that's used. So here's a patient with pain, bleeding, and they're pregnant. Something we see all the time in the ER. And this is, of course, hopefully everyone knew, ectopic pregnancy. So the important thing here is we see an empty uterus. That's the first observation you always want to make in looking at a first trimester pregnancy. Is there an intrauterine pregnancy? The next thing, which is somewhat harder to kind of visualize, is that all of this back here is coagulated blood. So you might see some echogenic free fluid as well, but there's tons of blood in the cul-de-sac. And then we see an echogenic ring that is extra ovarian. So here's the ovary, and next to it is this echogenic ring. So that diagnoses ectopic pregnancy, which hopefully you all know that. But that brings us into the other part of the guidelines, which is now what we have termed a pregnancy of unknown location. So let's see, you see an empty uterus, you don't see an echogenic adnexal ring, you don't see free fluid. What do? They're hemodynamically stable. We call this we used to just say ectopic pregnancy cannot be excluded. Now we call it a pregnancy of unknown location. I can honestly tell you that I never look at the beta HCG in these cases. I hear all the time people want to know what's the beta, what's the beta, what's the beta. I never know the beta. I don't really care what the beta is necessarily. It's not that I don't care, it's just it doesn't change how you should approach these cases. So your job, in my mind, as a radiologist, is to diagnose whether there's an intrauterine pregnancy or not, or whether you see signs of ectopic. If the beta is 5,000 or 1,000, the obstetrician or gynecologist has to take that data, synthesize it with your report, and then decide what to do about it. I don't ever look at the beta because it doesn't change my interpretation. As a matter of fact, it could almost screw you up into thinking, it's too low, that's probably nothing, or it's high, it's this, we should tell him to do that, this or that. My advice is not to not look at it, but don't let it interfere with your interpretation. So just as a caveat, I was an internal medicine doctor before I was a radiologist. So I came into radiology, I want to know all this clinical information, I got all this data, all this stuff, and it actually kind of screwed me up because I would take all that and try and look at the images and make these diagnoses, which is of course good, but at the same time, I had to actually retrain my brain to be a radiologist to look at the images and interpret what's in the images with the background knowledge of the clinical data. And it really is a different process, which I'm sure you all know, but the kind of that concept falls into place with this beta topic. So just so you know, we used to use 2,000 as the beta as the discriminating factor. It's been up to 3,000. Reason being is they were treating people for ectopic with methotrexate that had an early IUP, and now you've got a disaster on your hands because you've got this baby that's now growing, but it's been exposed to methotrexate, and that's really bad. So if you have a single beta less than 3,000, they advise against treatment for ectopic. Single greater than 3,000, so greater than 3,000, there's still a 0.5 chance of viability. And the most likely diagnosis is non-viable IUP. So even still, they're going to follow it up with a beta or ultrasound. So again, I would stay out of that realm of deciding what to do based on the beta and interpret the image based on what you see, IUP or no IUP. So this was a case that I saw a couple years ago, and an obstetrician actually scanned it in the office and said, oh yeah, okay, there's an IUP. Called this a SAC. I looked at it and said, I'm not convinced that's a SAC. I think you should get a follow-up. So that brings us to this part of the recommendations that they put in there. And this is what they suggest. Any round or oval intrauterine fluid collection most likely represents an intrauterine gestational sac and should be treated as such. It is much less likely to represent a pseudogestational sac of ectopic. And I would say that's absolutely true, and you should understand that in interpreting these. But you do need to be aware of the dangers. So if you go back to that case, this is a pseudogestational sac of ectopic. So I could have reported it this way, But I said, I'm concerned. This does not satisfy criteria for an IUP, and I'm concerned. She didn't believe me. The patient ended up going out and rupturing and ending up in an ER somewhere. She survived, but it was not good. When you see a SAC, if you were going to call it an IUP, you want to see what we call the double decidual SAC sign. And the way I was trained, which is by my dad, who ran this department for many, many years, he always said, when you're calling an IUP based solely on a double decidual SAC, make sure you find the image that you're going to put up in front of a court of law that says, that's the one I chose to call it the double decidual SAC. And I've always used that. So whenever I'm kind of, I don't know, I wouldn't put that one up in front of the court to say, yeah, that's a double decidual SAC. So you really want to see this double decidual SAC sign, which hopefully you all know about. This is the verbiage I use, which kind of ratchets theirs down one step, which is, there's an intrauterine sac-like structure in the setting of a positive pregnancy test. Statistically, this most likely represents a gestational sac. However, it does not satisfy strict criteria for an IUP. So recommend follow-up with ultrasound or beta to exclude ectopic. I think they're both accurate, but this kind of shows people, hey, I'm not really happy with this, and you should be careful. This is just back to a more esoteric case. This is anencephaly. Anytime you see these kind of owl's eyes, it's more of just a boards type case. Similar with this one. I won't belabor it too much. So this is none of the above. And this is amniotic band syndrome. So this is a thin, wispy. Just want you to see what amniotic band syndrome looks like for a specific region, not because you'll probably ever see it, except maybe on a test, but you see these wispy bands, this really swollen limb with these constricting bands because there's bands wrapping around it. The reason I show this is A, so you know what amniotic band syndrome looks like, but B, because I not infrequently get asked by my partners, hey, do you think there's an amniotic band here? Could this be amniotic band syndrome? Or at UCSF, we used to get these referrals, rule out amniotic band syndrome. So this is something called a synechnium. It's a band, it's like a scar in the uterus. If you turn sideways on it, you'll get this kind of gear shift type appearance. This is not amniotic band syndrome. It's not something you need to worry about. The other thing that can kind of mimic it is this kind of band here. It's a circumvallate placenta. The placenta is just sort of rolled up on the end. You can tell that these things look totally different than amniotic band syndrome, so don't start worrying about amniotic band syndrome every time you see a band-like structure inside the uterus. Okay. Again, a little more esoteric, but shown for a reason, because if you're taking, these kinds of things do tend to show up on the boards, I guess. So if you were to see this in real clinical practice, you'd probably freak out. So this is the first case. So we've got a 19-week, 2-day fetus. This is the femur measure. It's measuring 15 weeks, 4 days. Then there's a couple other findings here. So see if you can decide what you think that might be. And then this is a companion case, view of the brain and the head. Again, if you use your bones, this is the spine, the ribs, the heart, which is filling the chest. And again, we look at the femur length, 23-week fetus, femur length is 13 weeks. So the first one was thanatophoric dysplasia. We see this short femur, it's curved, it's what we call a French telephone receiver femur. We see a very small chest, The ribs only come about halfway around. They should come all the way around almost, at least 2/3 of the way. We also see platyspondyle, and we see a normal looking skull. In this case, we see beaded, broken, angulated ribs, and there's no skull ossification. The reason this picture looks so nice of the brain is because there's actually no skull here, and you see the upside ventricle normally and the downside ventricle normally, and all the brain parenchyma just looks hypoechoic. So the reason I show these is obviously in real world you're not going to ever see one of these, and if you did, you'd probably just say, oh my god, there's some severe looking skeletal dysplasia or something doesn't look right, and you'd send it on for additional imaging. However, on the boards, I'm assuming they still show stuff like this. People, including myself, when you're studying for these things, tended to basically have a heart attack every time someone mentioned the word skeletal dysplasia because they all seem so complicated and weird, which is true because there are so many types. But if you look at this 23 center experience, where there was only, in these 23 centers, 139 cases, 78 of them were these two. So if you're ever going to see something like that, it's probably going to be one of these two. And the other one was achondrogenesis, which was 9. Heterozygous achondroplasia, it's not really an ultrasound diagnosis per se. Short rib polydactyly, you're going to see multiple digits, so that's kind of easier to sort out. So you're left with these three things. These we already know. You have the short femur, short ribs, which they both have, but it has the platyspondyle, if you know what to look for, and a normal-looking ossified skull, except for one type that has the Kleebott-Shadle skull. Osteogenesis imperfecta has got the short femur as well, but the beaded, broken, angulated ribs and no skull ossification. So they look different from one another. And if you were shown something like this, which you probably wouldn't, but again, short femur, short ribs. And the trick here is that there's no spine ossification. So the three of these look very different, and they're the three most common of an extremely uncommon entities. Here's what the achondrogenesis looks like. If we go back to our talk about looking for the bones, you see there's no spine here. There's just no spine anywhere here. You don't even know where the posterior anterior is. And there's no sacrum here. And this is what an x-ray of one of these babies looks like. So I show it really just for that, and to mention that what we really see in normal practice is something that looks like this. We get this biometry sheet, and you see your gestational age is 35 weeks, 0 days. Your ultrasound age comes out to 36 weeks, 5 days, but oh my God, look here, the femur is in the 5th percentile, and it's way behind all these, and you're like, oh my God, is there a skeletal dysplasia? What am I dealing with? The reality is, if you look at this femur compared to those, it morphologically just looks totally normal. There's nothing weird looking about it. And if you actually go up and compare, okay, so the femur is measuring 33 weeks, 6 days. Forget about all these numbers. So let's just say for 34 weeks. The gestational age is estimated at 35 weeks. It's 1 week off, not a big deal, not something you'd freak out about. So this is what you tend to see not infrequently in real life, and that's kind of how you want to work through it. Does it look normal, and how does it really compare to the actual gestational age? So here's a right adnexal mass on physical exam. Sorry, I bumped into that fast, but you might think it's an endometrioma. But the critical thing, anytime you're looking at something you think is an endometrioma, is to do color flow and spectral, and then take a spectral tracing over the color flow. And in this case, we actually see some arterial flow in there. You can have an endometrioma with septations running through that have flow, but in this case, this is actually a solid lesion. This is a fibrothecoma type tumor, and if you cine through these, they can actually have the Venetian blind shadowing, kind of like a fibroid does. But this is a solid ovarian mass. It's not an endometrioma. You can see an endometrioma doesn't look all that much different. It's that sort of homogeneous low-level echoes. the endometrioma shouldn't have flow in it. You can always use MRI to troubleshoot. The other important thing with endometriomas, you want to look for these, always look for these echogenic wall reflectors. And those, if you see that, it's almost 100% likely to be an endometrioma. So if you see those, you're done. This was a case we had, kind of looks like endometrioma, don't see any echogenic wall reflectors. So in that case, do an MRI. You do the MRI, and this is an endometrioma on MRI. I know you've seen that before, but FAT's at T1, it's bright, blood products, you're done, endometrioma. In this case, here was that thing, bright on T2, not bright on T1. This is an ovarian neoplasm. So if you don't see the echogenic wall reflectors, do an MRI. That's my rule of thumb. This was a baby with an abnormal quadruple screen. And this shows a double bubble, an AV canal defect, and some mild pelviectasis. This is Down syndrome. The reason I showed this one is because this was actually missed by someone, a partner of mine. They thought this was a normal heart. So that's because it's very easy to mess this up. The tech also missed it. So you see here, I'm going to show you on this cine clip of the heart. If you freeze it, so remember an AV canal defect has this giant monoventricle in the middle of the chest, in the middle of the heart. And if you freeze your image while it's open, there's nothing about this that even looks like a heart. It's just sort of this amorphous hypoechoic structure in the middle of the chest. If you freeze it when that valve is closed, you could actually decide that's a relatively normal 4-chamber view. They all have kind of a patent foramen ovale, so you can get, oftentimes don't see a real good, an ASD here. So I could see how that might make someone think that's a normal heart. So what I always do is look individually at the valve. So remember, if we identify the chambers, you got your descending aorta, left atrium, left ventricle, right atrium. So you want to look at both atrioventricular valves and make sure they're opening normally. Here you can see that it's just this giant sort of monovalvular structure in the chest opening and closing. This is nothing too complicated, but good thing to know about. This is a funneled cervix with prolapsing membranes. Cervix is actually not shortened, it's just open. And one thing I always tell my techs is if you see anything funny with the cervix, have a very low threshold for doing endovaginal imaging. They never want to do it because it takes more time, but have a low threshold. We're looking at this structure right here. That's a serous cystic neoplasm of the pancreatic head. So these are one of the microcystic tumor, these used to be called. But good to kind of know your anatomy, where you are, where you're looking, so you can identify what structure this is in, and then know that you're in the pancreas. This is an adrenal hemorrhage. Trick here to know that you're not, this is a neonatal, you're looking at a tiny transducer. How do you know it's not a renal mass? It's because you've got this triangle of fat in between the kidney and this other structure, so you know this is extra-renal. So that's a neonatal adrenal hemorrhage. This is a sequestration. So again, you're in a fetus. You see ribs, spine, so you know you're in the chest. This is the heart. And we see a feeding vessel coming off the descending aorta. 3 most common chest masses, we already showed the CDH. Sequestration, you'll see this. CCAM usually have multiple tiny cysts like this. They're really echogenic, shifting the heart over again. going to go over some twins really fast. This is another thing I see people kind of messing up a lot. First trimester twin pregnancies, how do you diagnose chorionicity and amnionicity? I still see a lot of my partners saying, oh, there's a twin pregnancy, and they don't say whether they're dichorionic or monochorionic, which is the key thing. So this is dichorionic diamniotic. This is monochorionic diamniotic. So the trick here, because I think this is what throws people off, is that the word chorion substitute for the placenta. So dichorionic, there's going to be 2 placentas. Monochorionic, there's going to be 1 placenta. The important thing is that monochorionic pregnancies share placental circulation, and you run into twin-twin transfusion syndrome. And what happens a lot is that people don't diagnose it as monochorionic early on, and they end up getting in trouble. So this thick intertwin membrane is the key thing here, and that's because you have the 4 layers, 2 chorionic layers, 2 amniotic layers. The problem is, as the pregnancy goes on, that membrane stretches out. So there's the trick we can use kind of in between when that happens. So here we have something that looks like really 1 placenta, because they're on the same side, but you have this thing called the twin peak. That's because there's placenta growing, or chorionic tissue growing into that membrane. Whereas in the first trimester with a monochorionic pregnancy, there's only 1 placenta, and the only thing intervening between these 2 is this thin amniotic membrane. So I think I have a picture with all of them together. So dichorionic diamniotic, monochorionic diamniotic. Look for this thick intertwin membrane. That'll help you every time. This is kind of like the final exam, if you could get that. This is dichorionic, but triamniotic. So, but same rule. Thick membrane, that means there's 2 placentas, but this is a monochorionic pair, and then between these 2, it's dichorionic. I'll kind of just show you this picture, but I know he covered this in the last one. So this is a partial mole. He showed it on MRI and CT, I think, with the thecal lutein cyst, but basically we see this embryo, it's dead, and there's a lot of cystic spaces in the placenta. Anytime you see cystic spaces in the placenta tissue, you need to think about a mole. And if you see any fetal parts, if you see a yolk sac, if you see an amniotic sac, if you see an embryo, it's a partial mole, which is from 2 sperms and an egg. The complete mole, where there's no embryonic parts, is just a bunch of cystic spaces or hydropic villi within placental tissue, and that's when a sperm fertilizes a genetically empty egg. So this is a series of cases, really, to finish it up here. Oh, sorry, I bumped to the answer, but this is a cornual ectopic. So anytime you see a gestational sac that's very eccentrically located, you want to think about a cornual ectopic. Now, you can have eccentrically located sacs, but what you want to do is, this one doesn't really, but a lot of times you'll see them sort of bulging this out. But if you draw a circle around the gestational sac, and then a circle, and then kind of where the myometrium is, you do not see myometrium surrounding this sac in all planes. So you know that this is not intrauterine. To have an intrauterine pregnancy, you want to see myometrium surrounding it in all planes. This is kind of similar, sort of low-lying. This is the uterus up here. You've got this low-lying sac. It's not an abortion in progress, it's a cervical ectopic. So with the, I'm going to go back to this picture real quick. You kind of see how the cervix is bulging. It doesn't come down and taper and it's flat. That bulging cervix is the sign that it's not an abortion in progress. The other key thing is to look for this trophoblastic flow around it. If you see that, then you're dealing with a cervical ectopic, not just an abortion in progress. So you want to look in grayscale. And then the last one, and I literally saw one of these yesterday morning. is a C-section scar ectopic. These are becoming more and more common. They're not common, but they're becoming more and more common because people are doing so many more C-sections. And this is actually one case in which you will potentially see some myometrium surrounding the sac, because it's not that it's extrauterine, it's that it's implanted into the C-section scar. So you see the cervix here, and here's this pregnancy right here, right above the cervix, eccentrically located. So here's the here's the endometrial canal, which is coming down like this, and this is eccentrically located anteriorly. And I could have superimposed this picture from yesterday, literally, they look like this almost every time, and you will see those, so it's important to know about. This you probably won't see, but I just want to show it because you see it on board exams sometimes. And this is holoprosencephaly. The reason I show it again is because when I was studying, I always got confused with holoprosencephaly or hydranencephaly or hydrocephalus. And again, they don't look exactly the same, so you can make the distinction. Holoprosencephaly, you're going to think about this horseshoe-shaped monoventricle. That's usually the main thing you'll see. You've got the fused thalami. You could kind of imagine in hydranencephaly that this is a horseshoe-shaped monoventricle, but you don't really see any brain parenchyma. This is basically just like massive infarcted tissue. I like to think of it as a massive stroke bilaterally. And then with hydrocephalus, it's going to look like hydrocephalus.